Assalamualaikum. I welcome you all on behalf of Med Exam Expert. Our topic of discussion today is amenorrhea. Amenorrhea is basically classified the absence of menstruation by the age of 16 if the patient does not have secondary sexual characteristics, or age of 14 if patient has secondary sexual characteristics. Amenorrhea is basically classified according to the cause. It can be physiological as well as pathological according to the onset. It can be primary amenorrhea and secondary amenorrhea according to hidden or apparent, cryptomenorrhea or true amenorrhea, and according to plan for workup, it can be physiological, anatomical, as well as endocrinological. Okay, according to the endocrinological, there are 4 subtypes. Whether the breast is absent or present. Number 1 is absent breast and presence of uterus. The second is breast is present but the uterus is absent. The third one is breast is absent and the uterus is absent. And the fourth one is breast is present and the uterus is also present. So this table is showing the algorithm for workup if the breast is absent and the uterus is present. We will go for serum follicle stimulating hormone. If it is low or normal, then this is hypogonadotrophic hypogonadism. And if the serum FSH is high, then the patient is having hypergonadotrophic hypogonadism, which is also called gonadal dysgenesis. However, if the patient has breast but the uterus is absent, we will go for karyotype. We will see whether the karyotype is 46XY or 46XX. If the karyotype is 46XY, then the patient is having androgen insensitivity syndrome, that is normal breast and absent sexual characteristics and absent pubic and axillary hair. But if the karyotype is 46XX, it means the patient is having Mullerian agenesis, which is also called Mayer-Rokitansky-Kuster-Hoster syndrome. In this, the patient has normal breast development as well as the normal axillary and the pubic hairs. However, if the breast is present as well as the uterus is present, we will see the level of progesterone. If we give the progesterone to the patient and the patient has bleeding, it means the patient was having chronic anovulation, that is polycystic ovarian syndrome, which was the cause of amenorrhea. But if after the administration of progesterone, the patient is not having bleeding, we will give the combined preparation of estrogen as well as the progesterone, and we will see whether the patient bleeds or not. If there is no bleeding, then it means there is some uterine factor for amenorrhea, that is most common cause is Asherman syndrome. However, if the patient is having bleeding, it means the patient is having ovarian failure and the primary amenorrhea and understand how to perform and interpret selected diagnostic tests and imaging to evaluate primary amenorrhea. So let's talk about the mechanism of puberty. The puberty is basically initiated by the pulsatile release of gonadotropin releasing hormone. And specifically, there is increased pulsatile pattern of follicle stimulating hormone and luteinizing hormone. These hormones start to increase during sleep and eventually they go throughout the day. With the pulses of gonadotropin releasing hormone, peaks of estradiol result, and finally menarche appears. By late puberty, the mature hypothalamic pituitary ovarian axis is intact and ovulation does occur. So what is the timing of puberty? The main determinant for the timing of puberty is genetic. This is also affected by geographic location, exposure to light, general health, nutrition, and psychological factors in the patient. Recent studies have demonstrated a reduction in the age of menarche, and there is role of body weight also. Studies show that 47 kilogram weight in general then the patient can have the normal menstruation. However, there's shift in body composition to more fat, then there is 16 to 23.5% chances of having the amenorrhea. And in some cases, this has been linked to protein leptin. So friends, let's talk about the stages of pubertal development. There are 4 stages of pubertal development. The first one is accelerated growth. Then there is breast development, which is also called thelarche. Then there is the phase of pubarche, and finally menarche. All these stages takes 4.5 years, and they differs culturally between different ethnic groups. So this table is basically showing the mean age of thelarche, adrenarche, and menarche in different population. See the last column, the Caucasian girls, they have the mean age of thelarche and adrenarche at 10.5 years, and the mean age of menarche is 12.7 years in these girls. So how do we assess the pubertal development? Pubertal development is basically assessed by Tanner staging. Tanner staging was developed by Sir James Tanner and originally published in 1968 as an objective way to assess the pubertal development. All right, there are 5 stages in the Tanner staging. The prepubertal is also called the stage 1. There is elevation of the breast papilla only. However, there is no pubic hair development. In the stage 2, there is elevation of the breast and papilla. Small bone areola diameter is enlarged. Pubic hairs are sparse, long, pigmented, and chiefly along the labia majora. In the stage 3, further enlargement of the breast papilla occurs without separation of the breast and areola. And the pubic hair, they are coarse, curled hairs, sparsely separated over the mons pubis. In the stage 4, there is secondary mode of areola and papilla above the breast, and the pubic hair have the adult type presentation, and they are abundant but limited to the mons only. In the stage 5, there is recession of areola to the contour of breast, and in case of pubic hair, they are adult type and they are spread in quantity and distribution. So this diagram is basically showing all the 5 stages of Tanner staging, as you can see here, the male as well as in the female. Now let's talk about the causes of primary amenorrhea. According to American Society of Reproductive Medicine, the causes of primary amenorrhea are basically classified into 3 main groups. Primary amenorrhea with breast development, which is found in 30% of the patient. Primary amenorrhea without breast development and high follicle stimulating hormone seen in 40% of the patients. And primary amenorrhea with no breast development and low follicle stimulating hormone, which is seen in 30% of the cases. All right, this table is showing the percentage of different disorders which are associated with the primary amenorrhea. As you can see that the primary amenorrhea with the presence of breast is present in 30% of the cases. Agenesis is found in 10% of the patient. Insensitivity in 9% of the patient. Vaginal septum 2%. Imperforate hymen 1%, and constitutional delay is found in 8% of the population. No breast development along with the high follicle stimulating hormone is seen in 40% of the cases, as well as no breast development and low follicle stimulating hormone is seen in 30% of the population. Now, the most important cause of primary amenorrhea is Mullerian agenesis. This is also called Mayer-Rokitansky-Kuster-Hoster syndrome. What happens in this syndrome, friends? There is complete absence of uterus, cervix, and upper 2/3 of the vagina. This is found in 1 in 5,000 of the female newborns, and the patient has normal X karyotype. There is normal ovarian function and normal pubertal development. And the main causes of this Mullerian agenesis are mutation in some of the hormone receptor, like anti-Mullerian, as well as the changes in hormone level. Now, how do we evaluate patient of Mullerian agenesis, as these patients have normal breast development and normal secondary sexual characteristics. And on laboratory investigation, they have the normal karyotype, that is 46XX. They have normal luteinizing hormone as well as the follicle stimulating hormone. However, on pelvic examination, they have normal external genitalia, but there is absence of internal midline structure, and vagina is present in the shape of vaginal dimple only, as there is absence of upper 2/3 of the vagina in these patients. Okay, this is the MRI of the patient who is suffering from Mullerian agenesis, that is Mayer-Rokitansky-Kuster-Hoster syndrome. As you can see on the right side, this is the MRI picture of a normal patient who is having the uterus, but on the left side, you can see that there is absence of the uterus. Many of the conditions are associated with Mayer-Rokitansky-Kuster-Hoster syndrome. In one of the cases, there is also associated urinary tract anomalies. These patients are prone of having ectopic kidney, renal agenesis, and mostly they have the horseshoe-shaped kidney. 12% of the people, 12% of the female, they have the associated skeletal abnormalities, especially the spinal anomalies, absent digits, webbed fingers, and toes. So the part of workup needs to include an abdominal CT scan to evaluate for the associated renal anomalies if they are not found on the ultrasound. Now coming towards the treatment of Mullerian agenesis, the most important step in the treatment of patient is the counseling of the patient about the problem, to tell that she is normally a female with a normal karyotype, that is 46XX. This is the most important step in the treatment of patient, along with the psychological counseling. So what we offer to the patient, we offer dilators to the patient. There are different dilators, the most common being the Frank dilators, and we advise the patient to dilate at a 15-degree angle daily after warm bath for 15 to 20 minutes. Progressively, the patient will work towards the larger dilator, and the success is defined as non-painful intercourse or vaginal length of at least 7 centimeters. Studies demonstrate there is success rate of 88 to 90% at 19 to 20 months of use. The patient who do not get any benefit from the dilator, we offer the surgical treatment, and the most important surgical treatment is the creation of neovagina. In this, we use a skin graft or artificial skin, which is placed over a mold, forming a tube with one closed end. We give an incision in the vaginal dimple, and cavity is dissected to the level of peritoneum. Then the labia majora, they are sewn together, and the patient is advised to have bed rest for 7 days, avoid the sexual intercourse, and then after a period of 7 to 10 days, the mold is removed. This diagram is showing different steps in the process of the Mecon neovagina, which is one of the procedure to create the vagina in the patient who are having the vaginal dimple. Okay, there are some other forms of surgical management for the patient who are suffering from the Mayer-Rokitansky-Kuster-Hoster syndrome. However, these procedures are not commonly done nowadays. Just have to remember the names of these procedures, the most important being the Williams vaginoplasty, in which we use the labia majora in order to create the new vagina. But the disadvantage is that it leads to shortening of the vaginal cavity. Sigmoid vaginoplasty can also be done, in which a part of the sigmoid colon is pulled to the level of introitus, followed by end re-anastomosis. The advantage is that the vaginal length is preserved, but it is associated with a foul-smelling vaginal discharge afterwards. Vishiti vaginoplasty was also done in the previous days. This was a creation of neovagina by invagination. Small acrylic mold is placed in the vaginal dimples, and the abdominal incision is made. Traction is applied with the help of stitches on the abdominal peritoneum, and this peritoneum is attached to the mold. Then that traction device is used to pull the mold up to 1.5 centimeters per day, and it takes approximately 7 to 10 days for the healing. All right, the second most important cause of primary amenorrhea in patient is the transverse vaginal septum. What happens in this condition, friends? There is failure of canalization of distal third of the vagina, and this is most common in the upper and middle third of the vagina. The diagnosis is basically made, the patient presents after puberty with primary amenorrhea and pelvic pain. The patient can also present with the hematocolpus as well as the hematometra. The point of differentiation from imperforate hymen, which is another cause of primary amenorrhea, is that the transverse vaginal septum patient, when we examine them, the septum or the bulge, this does not bulge with the Valsalva maneuver. However, the diagnostic tool is MRI. All right, this diagram is showing the presence of vaginal septum. On the right side, you can see that there is a septum, which is the cause of primary amenorrhea in the patient. The second most important cause of primary amenorrhea in young girl is imperforate hymen. This is most common obstructive lesion of the female genital tract, and it affects every one female in 1,000 female births. There is some classical appearance of this condition. There is a bulging blue dome translucent membrane, and the patient can also present with a hematocolpus or the urinary retention. It differs from the vaginal septum in that an imperforate hymen bulges with the Valsalva maneuver, and this point is the most important point to differentiate it from the transverse vaginal septum. And the second differentiating point is that the membrane of imperforate hymen is bluish pink, whereas in case of the transverse vaginal septum, the septum is mostly reddish pink. Treatment is basically done by surgery. We give a cruciate incision on the bulging part of the membrane. Another most important cause of primary amenorrhea is androgen insensitivity syndrome, which affects 1 in 50 to 60,000 population. Although 9% of causes of primary amenorrhea, they are linked to this condition. Genetics plays an important role. This is an X-linked recessive condition. Phenotypically, these are tall, beautiful female, and they have the genotype XY. They have female external genitalia with small vaginal dimple. The uterus is absent. They have the gonads, which are present. They have absent axillary and pubic hair because the androgen receptor is not responding to the androgen level. However, they have the normal breast development because there is absence of the anti-Mullerian hormone. The most common cause is mutations in the androgen receptor. So what is most important step in patients who are suffering from the androgen insensitivity syndrome? Location of testicular gonad. They can present in intra-abdominal So we recommend removal after complete pubertal development to enhance the bone maturation and puberty. The recommended age for gonadal removal is 16 to 18 years. Once the testes are removed, then these patients are treated with hormone replacement therapy. The gonads are removed in these people because the incidence of neoplasia is 22% in the gonads. And the most common histology in gonadal malignancy is the Leydig cell hyperplasia as well as the Leydig cell tumors. All right. It has normal breast development. The frequency of primary amenorrhea is 30%. However, if the patient has high follicle stimulation, not developed, the incidence is 40%, out of which 15% have the karyotype of 46XX and 5% have karyotype of 46XY, and 20% cases have the Turner syndrome or the Turner mosaic. So what is Turner syndrome? Turner syndrome is basically 45X not or mosaic. Incidence is 1 in 2,500 to 10,000 live bonds. 99% of pregnancies, they are affected by the condition, and the most important cause is absence of ovarian determinant gene, which results in premature loss of germ cells. There are some specific features in the patient who have the Turner syndrome, like webbing of the neck, widely spaced nipples, wide carrying angles. So As the gestation continues, there is accelerated loss of germ cells in intrauterine life, and many of these individuals, they lose all the germ cells prior to birth. Less than 15 to 20% have enough germ cells to start the pubertal process by puberty or adolescence. So these diagrams show different features of the Turner syndrome. You can see they have short stature, low hairline, shield-shaped thorax, widely spaced nipples, shortened metacarpal joints, small fingernails. Sometimes they have brown spots, which are called the nevi at different skin. And the most important feature is that these people have primary amenorrhea. There are many associated abnormalities in patients who are suffering from Turner syndrome, the most common being the coarctation of aorta, which is present in 30 to 40% of the patient. Also, they suffer from bicuspid aortic valve, mitral valve prolapse. So it is recommended that echocardiography should be performed every 3 to 5 years to detect these abnormalities. They also have associated renal anomalies, the most common being the horseshoe-shaped kidneys. So they need retroperitoneal ultrasound once they are diagnosed with the Turner syndrome to detect all these renal anomalies. 10% of the patient, they also have associated features of hypothyroidism. So it is recommended that thyroid function should be tested yearly in these patients. Many of the people, they have the sensory neural deafness. Now coming towards the gonadal dysgenesis, which is another cause of primary amenorrhea, this refers to a number of conditions in which there is abnormal development of the gonads and it leads to streak gonads. Many causes are there. Familial inheritance is present in 7 to 30% of the people. There are some mutations in the Fragile X syndrome gene. 15% of the carriers, they have premature ovarian failure. In 18 to 35% of the cases, this is associated with autoimmune diseases, the most common being the Hashimoto's thyroiditis, Addison disease, hypothyroidism, as well as the vitiligo. There are some acquired causes of gonadal dysgenesis, the most common being radiation, chemotherapy, as well as some of the childhood viruses. So the diagnosis is made if the patient presents with a history of more than 3 months of amenorrhea, and the follicle stimulating hormone is high. It is mostly in the menopausal range. If we do the ultrasound in these patients, more than 60% of the people, they have undetectable ovaries by ultrasound, and majority of them show no follicular growth. DEXA scan is done in addition to screening for autoimmune diseases. So what is the treatment? The treatment is basically the hormone replacement therapy, that is low dose estradiol, 1 to 2 milligram per day, and then the dose is built in a step-up manner for 12 to 18 months. After the addition of estrogen to the patient, we add progesterone in order to regulate the menstruation in these people. 5 to 10% of the people, they can have the spontaneous pregnancy, as the patients with gonadal dysgenesis will cycle inconsistently. And we recommend OCPs in the adult population to prevent the unwanted pregnancy. So this slide again shows some of the causes, that is, they are associated with mutation in the gene. Streak gonads are present, no testis formation, therefore anti-Mullerian hormone and testosterone are not produced. So they have the normal uterus and fallopian tube. That's why the pregnancy is possible in these patients. They have the female external genitalia. Estrogen is not produced, so they have the streak gonad, therefore breast development does not occur. These patients also have elevated follicle stimulating hormone as well as the luteinizing hormone. As they have the streak gonad, so they need removal, as there is increased chance of malignancy, and the most common being the gonadoblastoma in the patient who are suffering from gonadal dysgenesis. And the treatment, I have already told you that we give the estrogen, and after giving the initial dose of estrogen, we give the progesterone for completion of the menstruation. So this table also showing the different incidence of the primary amenorrhea. If the patient has primary amenorrhea with breast development, 30% frequency is there, 40% frequency if there is no breast development along with high follicle stimulating hormone, 30% if the follicle stimulating hormone is low along with the no breast development, 10% of the people, they have constitutional delay, Prolactinomas, most important cause of secondary amenorrhea. This is present in 5% of the population. Kallmann syndrome in 2%. Other CNS disorders, as well as stress, weight loss, anorexia, and PCOS, they account for 3% of the cases. Prolactinoma, most common cause of pituitary-related amenorrhea. Elevated prolactin releasing hormone level, it can suppress the hypothalamic gonadotropin releasing hormone secretion. So there is greater disruption of the menstrual cycle. The most important is to rule out the hypothyroidism and the medication use in these patients. We can do the MRI of the pituitary fossa if the prolactin releasing hormone level is more than 100 nanogram, or if the patient has visual symptom. The treatment is basically bromocriptine or cabergoline to lower the level of prolactin, and 80 to 90% of the patient with hyperprolactinemia, they will have improvement, and 80% of the microadenomas, they will shrink with this treatment. If the medical therapy fails, then the patient can have the transsphenoidal surgery. This is the MRI of the patient, and it is showing an 8 millimeter prolactinoma in a patient, as you can see in the diagram. All right, prolactinoma, non-functional tumors, metastatic tumor, space-occupying lesion, aneurysm, Sheehan syndrome, panhypopituitarism, hemochromatosis, and sarcoidosis. These are other causes of the amenorrhea, but mostly they cause the secondary amenorrhea rather than the primary amenorrhea. So what is the hypothalamic amenorrhea? Functional hypothalamic amenorrhea is related to stress, nutrition, and exercise. There is alteration in the normal pulsatile release of gonadotropin releasing hormone. There is complex interplay between different neuropeptides, and when there is disruption, this can lead to amenorrhea in the patient. Lower levels of leptin are seen in the patients who are suffering from anorexia, and this reduced level of leptin can cause amenorrhea. Cortisol has an important role as stress-related levels of corticotropin-releasing hormone. It interferes with the release of gonadotropin-releasing hormone, and this will affect the hypothalamic pituitary ovarian axis. The patient who do excessive exercise, they also have the chronic imbalance between caloric intake and consumption, and this leads to hypothalamic dysfunction, finally leading to amenorrhea in the patient. Primary amenorrhea is also related with the eating disorder, and despite the definitive treatment, adults with eating disorder and primary amenorrhea, they progress through puberty at a very slow rate, and the estimate weight at which menarche will resume by prepubertal weight is 47.8, as I already told you. Female athlete triad was established as a diagnosis in 1992, and the patient presented with amenorrhea, osteoporosis, and most of the people, they were having the eating disorder, and it was common among the female athletes. The most common people affected were gymnastics, ballet dancers, and long distance running. In these patients, we have to do the bone mineral density evaluation, as the athletes generally they have the higher bone mineral density. A Z-score less than -1 requires evaluation. Regarding treatment, we have to counsel the patient about the eating disorder. There are some screening tests which are done. For example, the SCOFF questionnaire. This is one of the questionnaire which is used to assess the eating disorder in the patient. Eating attitude tests. Minimal goal should be the 30 kilocalories per kilogram of lean body mass. And these people must be encouraged to have dairy products in the diet, as well as iron and protein-rich foods. However, if the condition does not respond to initial treatment, they must be referred to the psychologist. There is some role of oral contraceptive because it leads to improvement in the bone mineral density, but it does not restore the bone mass to the age-matched controls. So we have to address the underlying pathology. Focused counseling should be done in these people, as it has proven success. Estrogen has an important role in the bone mineral density. As you can see that deficiency of estrogen results in increase in osteoclastic bone resorption and osteoporosis. And if there is deficiency of testosterone in males, this can also result in low bone mass density. So coming towards the Kallmann syndrome, which is another cause of amenorrhea, this is X-linked recessive mutation in the Kallmann gene, which codes for an adherent molecule, and this results in lack of migration of gonadotrophin releasing hormone neurons from the olfactory placode. These patients have characteristically have hypogonadotrophic hypogonadism, anosmia, midline facial defects. Sometimes they have associated renal tract abnormalities. They have absence of pubertal development as well as the primary amenorrhea. And the treatment is hormone replacement therapy to promote the sexual maturation, and fertility is possible in these patients with the use of gonadotrophins, injectable gonadotrophins. Polycystic ovarian syndrome is an important cause of normogonadotrophic hypogonadism in the patient, and this is one of the important cause of secondary amenorrhea. 5 to 10% of adult women, they suffer from the PCOS, and increasing prevalence is seen in the adult population. Diagnostic criteria, at least 2 of the following must be fulfilled, which is called the Rotterdam criteria. There must be chronic anovulation, clinical or biochemical evidence of excess androgen level, and polycystic ovaries on the ultrasound. These people typically present with secondary amenorrhea or oligomenorrhea. It is important to diagnose the metabolic abnormalities in these patients, as most of these patients, they have the diabetes mellitus as well as the sleep apnea syndrome. And recent study have shown that 62% have already developed insulin resistance before the diagnosis is made. They also have the dyslipidemia as well as the associated obesity. This is the ultrasound of a patient who is suffering from the polycystic ovarian syndrome. As you can see that the ovaries have multiple cysts. Now coming towards the congenital adrenal hyperplasia, this is also another important cause of amenorrhea in the patient. There is enzyme defect which leads to excessive androgen production. Milder form of the disease, they are diagnosed later in the life, that is the late onset congenital adrenal hyperplasia. It may present with the primary amenorrhea, but classically the patient have the feature of hirsutism, virilization, as well as the anovulation. Most commonly, this is due to defect in the 21-hydroxylase enzyme, which leads to an accumulation of 17-hydroxyprogesterone, which is its substrate. And the diagnosis is made on elevated level of fasting 17-hydroxyprogesterone. If it is more than 300 nanogram per deciliter, we will go for ACTH stimulation test. And if the level of ACTH stimulation test is more than 1000 nanogram per deciliter, this is an indication for late onset congenital adrenal hyperplasia. Constitutional delay is also another cause of amenorrhea in adult population. As you know, puberty occurs at a time greater than 2.5 standard deviation from the mean. Sometimes there is family history of delayed puberty. There are some characteristic features in the patient who have the constitutional delay. They have significantly shorter height, bone age that lags behind age-matched controls. Often they present at early Tanner stage 2. They have low gonadotrophin level, that is, they have hypogonadotrophic hypogonadism. The diagnosis is basically the diagnosis of exclusion. We have to exclude the other causes of reproductive disorders. As you can see, Mullerian agenesis is seen in 10% of the people, androgen insensitivity in 9%, vaginal septum 2%, imperforate hymen 1%, and constitutional delay is seen in 8% of the population. However, if the patient has high FSH and no breast development, which we have already talked is present in 40% of the cases, the most important cause is Turner syndrome and variant gonadal dysgenesis. If the patient have low follicle stimulating hormone along with absent breast, then the most common cause is constitutional delay. Prolactinomas can be there, as well as the Kallmann syndrome, PCOS, and stress-related amenorrhea can be another cause. All right, now how we will evaluate a patient of amenorrhea? Basically, the diagnosis is made on history and relevant examination is done. Then we go on the investigation. In the history, we will ask the patient about pubertal development, any premenstrual symptom, dysmenorrhea, whether she has cyclical abdominal pain, any medical history related to chronic illness, exposure to radiation, or any current medication which the patient is taking. This is important in case of the patient who are suffering from prolactinoma. Exercise, weight loss, any drug abuse, history of pubertal delay in the family, as well as infertility. Whether the patient is having anosmia, galactorrhea, headache, visual changes. Are there any features of hirsutism or acne? Are there any features of thyroid-related disease or any vasomotor symptoms for premature ovarian failure? Coming towards the examination, we will see the BMI of the patient along with the secondary sexual characteristic, and we will do the Tanner staging for breast and pubic hair development. We will see for any dysmorphic feature, that is webbed neck, short stature, widely spaced nipples, any features of hirsutism or acne. We will do the thyroid examination to rule out the thyroid disorders as well as the prolactinomas. Pelvic examination is most important step in the diagnosis of the patient who are suffering from amenorrhea, especially the primary amenorrhea. Whether the uterus is present or absent, is the uterus rudimentary, is there any vaginal dimple, transverse vaginal septum, imperforate hymen, any features of clitoromegaly or virilization. So investigation, buccal smear was done to examine the polymorphonuclear leukocytes to determine if the patient is chromatin positive. If the patient is chromatin positive, then probably she is having the karyotype XX, or chromatin negative in case of Turner syndrome or Turner mosaic. Hormonal investigation are most important, especially follicle stimulating hormone along with luteinizing hormone, estradiol, and testosterone level. Ultrasound will help to determine the presence or absence of uterus, and if the uterus is present, what is the state and size of the uterus, as well as the state of ovaries and any follicular activity. Laparoscopy is rarely done nowadays because in most of the patient, the diagnosis is made on history examination as well as the ultrasound. So how do we evaluate the patients of primary amenorrhea? As you can see, history and physical examination are completed for a patient who is suffering from the primary amenorrhea. We will see whether the patient is having secondary sexual characteristics or not. If the patient is having secondary sexual characteristics, the next step would be ultrasonography to see whether the uterus is present or absent. If the uterus is absent or abnormal, that is rudimentary, we will do the karyotype analysis of the patient. If the karyotype comes out to be 46XY, this is androgen insensitivity syndrome, which is again further subdivided into partial as well as complete. However, if the uterus is absent, patient is having normal breast development along with the karyotype, which is 46XX, then she is the case of Mullerian agenesis, that is Mayer-Rokitansky-Kuster-Hoster syndrome. However, if the uterus is present and it is normal, then we will see for outflow tract obstruction, whether there is imperforate hymen or transverse vaginal septum. If it is not the case, then evaluate for the causes of secondary amenorrhea, the most common being the Asherman syndrome, Sheehan syndrome, as well as the polycystic ovarian syndrome. However, if the secondary sexual characteristics are absent, we will measure the follicle stimulating hormone as well as the luteinizing hormone. If the follicle stimulating hormone and luteinizing hormone are on the lower side, that is less than 5 international unit per liter, then the patient is having hypogonadotrophic hypogonadism. The patient is having hypothalamic pituitary disorder or any CNS disorder. If the follicle stimulating hormone is more than 20 international units per liter and luteinizing hormone is greater than 40 international units per liter, it means the patient is having hypergonadotrophic hypogonadism. Then we will do the karyotype analysis to see whether the patient is having gonadal failure or not. Now coming towards the treatment. If the girl is having the normally developed breast, the uterus and the vagina are normal, and the patient is chromatin positive, the most likely diagnosis is delayed menarche. It is reasonable to wait for 1 to 2 years. Menstruation is not established in some people before 18 years of age. However, for those patients who have the diagnostic features of any pathology, the aim must be to restore the normal function. And although fertility may not be possible, for example, in cases of Tanner syndrome, they should receive the long-term treatment with cyclical hormones, estrogen and progesterone, or the hormone replacement therapy. And the patient who have the Tanner syndrome, some studies suggest that they have the increased chances of uterine carcinoma. In androgen insensitivity syndrome, the gonads are testes that are often found inside the abdomen or inguinal canal, and they have 25% risk of becoming malignant, that is teratoma or dysgerminoma. They should be removed after puberty, and an artificial vagina may be constructed or dilators used to help the patient in having the sexual intercourse. Treatment with estrogen should also be given to augment breast development and prevent osteoporosis in these patients. In cases of congenital absence of vagina and uterus, the ovaries are usually normal. An artificial vagina may be constructed to permit the sexual intercourse in these patients. Abnormalities of pituitary secretion should be treated with the estrogen or progesterone until the fertility is desired. So this was all about amenorrhea. If you have any question, you can unmute yourself and ask.
Madam, I have a question. Hello, can you hear me? Madam, I have a question. Hello.
Yes, my dear, you can ask.
Ji, madam, in the Sawyer syndrome, is
Yes.
the pregnancy is possible? Is that it's possible pregnancy in the Sawyer syndrome?
Sawyer syndrome, pregnancy is possible because what happens in the Sawyer syndrome, they have the uterus. You know, they have the streak gonads, and the streak gonads, they don't secrete any testosterone, as well as there is absence of anti-Mullerian hormone. If there is absence of anti-Mullerian hormone, it means there will be no regression of Mullerian structures. And the Mullerian structures will develop into uterus, vagina, ovaries, as they have the uterus. So pregnancy is possible in these people with the donor ovum in most of the cases. Did you get that?
Yes, madam, I get it. Thank you.
Thank you. Thank you so much for being an awesome audience. If you have any query, you can ask. All right, thank you so much. So this is time to say goodbye. Yes, yes.
Ma'am, if a young girl with a normal secondary sexual characteristics presents with the presence with the hypoplastic uterus on ultrasound,
Yes.
16 years girl, can we put this as a variant of MRKH?
Yes, my dear, this is variant of MRKH. Either they have the absent uterus or they have the rudimentary uterus. This is one of the variant of Mayer-Rokitansky-Kuster-Foster syndrome.
Yes, ma'am. The girl did not withdraw on the OCPs as well after 3 continuous OCPs.
All right.
For 3 months.
As the uterus was rudimentary, so this might be the cause that the girl doesn't have the withdrawal bleed.
Okay, ma'am. Thank you.
Thank you, my dear. So thank you so much for being an awesome audience. This is time to say goodbye. And still, if you have any query, you can ask us on the platform of MedExam. So good night from my side.